Okay, so now we're recording just fine. Okay, so I was just talking to Peter Kafka, who's about to join us. So let me see who we've got here. Okay, so Eric, Albert B, Bill Franklin. Woohoo! Bill Manning made it on. Hey, Bill.
Hi, Rick. How you doing?
Good. Let's see. We've got a lot of callers, so we'll get to the callers in a minute. Jake. Jeff Luddy. Jim Harrington. Who else? If I can see him, Len. Okay, gents. So let me just do the check-in. There's a bunch of guys that have called in, so I'm going to have to identify you. About 6 or 7 of you, so we'll have to let's go through the process of trying to figure out. You can call out your names slowly. Peter.
This is Peter Kaufman.
Okay.
You got me?
Yeah, I've got you. I've got you, Peter. Who else?
Okay.
Frank Kelly.
Frank Kelly. Hold on a minute.
Yep.
Frank.
Yep.
Okay, I think I saw you. I think you're number 5. And who else?
Dennis.
Say who was that?
Dennis Correa.
Hi, Dennis.
Hello, Rick.
Who else have we got?
Jim Cameron.
Hey, Jim Cameron. Jim Cameron.
I'll call before I return to Florida tomorrow.
So safe travels back to Florida tomorrow.
Yeah, I got to stop at John Hopkins on the way, then down to Florida.
Okay. Who else have we got?
Rick, to Steve.
Steve, where are you?
I'm home.
Oh, because you called in. Did you call in or did you call? Oh, you did. Right there. Hello.
Right there. Oh, I like. Well, look at you. Look at you.
Well, yes.
There.
This is because of my mum. I can't wait to get it off. I have another 3 or 4, 5 days, I think, but
it's a religious thing, huh?
It's a religious thing, yeah. It's a tradition rather than a religion. I lost my mother, guys, so the tradition is not to shave for 30 days. So that's what's going on.
I thought the tradition was to not shave and shave your head.
No, actually, no. That's what the pagans did. They didn't want us doing that too.
Right.
Oh, and I see that Jay Burton is with us. Jay, I'll introduce you momentarily. And anybody else who hasn't identified, or let me read who I've got, and then you can tell me.
Catapano's here.
Who is that?
Rich Catapano.
Hey, Rich Catapano. Now, let me tell you who I've got on the call, and then you'll tell me who I've missed. I got Eric Bookbinder, Albert Basilio, Bill Franklin, Bill Manning, Jake Hannum, Jeff Ledoux, Jim Harrington, Len Sierra, Peter Kafka, Frank Kelly, Dennis Correa, Jim Cameron, Steve Bornstein, and Rich Catapano. No? Okay. All right, so
Mike Tamales?
Mike Tamales, how are you, Mr.
Yes.
Tamales?
Very fine, thank you, Rick.
Good, good, good. Okay, so we have a couple of guests on the call today who I'd like to introduce up front. So nobody who's really new, although Bill Manning has not been on the call before, so we'll take a little bit of time to talk with Bill specifically. And then we have Dr. Jay Burton, who I was privileged enough to meet when I went to the Cancer Survivorship Conference in DC back in June. And Jay is a family practitioner back in Massachusetts, and he has his own group. He is a is it multiple myeloma? Am I correct, Jay? Are you with us, Jay? Well, I see his name, but I don't see, but we can't hear him. Maybe you're muted. Are you muted? Or maybe he'll be back with us. So I'll leave Jay until a little later on then, if he's not with us right now. But Jay asked if he could audit the call because he's thinking of doing something similar, and I was only too happy to invite him in.
Can you hear me now?
Yes, I can hear you now.
I'm figuring this out.
Okay, okay. Am I right, Jay? Is your disease was multiple myeloma, correct?
No. I was much more fortunate. I had acute myeloid leukemia.
Okay.
And not trying to be sarcastic, but they both can be pretty overwhelming and in their own right. But I had acute myeloid leukemia.
Okay. Well, one thing that you might be pleased to know is that I'm somebody who thinks they want to moderate a blood cancer call. So for too long we'll have a virtual blood cancer call, and so you can join in and contribute to that when you can do it. Just give us a quick rundown on your survivor program.
Well, I also had a stem cell transplant. This was back in 2010. I'm also a primary care physician for about 28 years, but in 2010 I was diagnosed, and I was feeling well, but I was diagnosed with acute myeloid leukemia. Anytime there's something that's acute in front of it, it means you got to do something pretty quick. And so I had in the abridged version, I had pretty quickly I had chemotherapy. After that, I developed pneumonia, lost about 50 pounds, got better, ultimately and was in remission with that first round of chemo. Ultimately had a stem cell transplant in October of 2010, and that included more chemotherapy and total body radiation. And then after the stem cell transplant, you basically have a year in quarantine. And during that time, I actually did a lot of my own primary care, if not all of it, and then kind of realized that I was pretty unique in what I could do. So I knew who to call, when to call, how to call, and get things done. And as I was getting better, I said, well, I'm in a pretty unique position. I got to try to find a way to make this better for other people. So I started a nonprofit called Survivor Journeys, and it's about providing the social and emotional support for cancer survivors, their families, and caregivers, at least initially in our area, which is the Springfield, Massachusetts area, which is about 90 minutes west of Boston, about 30 minutes north of Hartford, about 2 hours and 15 minutes northeast of New York City. And so we have a number of support groups right now, physical support groups that are cancer-specific support groups, blood cancer. We have 2 blood cancer groups that we work with the Leukemia and Lymphoma Society with. We have a bereavement group. We just started an all-cancer group for cancers that we don't have groups for. We have a breast cancer group. We are starting a melanoma group. We're partnering with the Melanoma Foundation of New England. And we have plans to do more groups. But more importantly, we're going to start a mentoring program in January where we're a junior member of a national organization called Volunteer Management in Cancer Care. And that includes Dana-Farber, MD Anderson, Sloan Kettering, Immerman's Angels, Friend for, which is in Chicago, Friend for Life in Kentucky. So we have we will have mentors who will help mentor people that are just going through their initial diagnosis and the initial phases. I found that it was extremely helpful when I was diagnosed. I was a doc and I didn't know anyone, and my local oncologist didn't know anyone really who had gone through a stem cell transplant successfully. But I had a friend who had a college roommate who had the same diagnosis. He was about 10, 15 years younger than me. But I had a couple of conversations with him, and it really made me feel at ease at what I had to do. And so I didn't think I was that unique that I would be the only one who would benefit from something like this. So that's why we're going to start a mentoring program, which is really going to be a great addition to our program. And I think that's kind of it in a nutshell. We've been a nonprofit for 1.5 years. We're moving forward, developing relationships with people who like to play nice in the sandbox. And that's when I met Rick at this meeting in June, which was about research and cancer survivorship. I'll leave out the details of our first meeting because I don't really know the audience, but I'm glad.
You can tell them. You can tell them that we met in the men's bathroom.
There you go.
Maybe had to do with the bottle of Jack Daniels or something, huh?
No.
Not in that bathroom.
As they like to say in England, we met in the men's hang out. British joke.
Okay.
Thanks, Jay. So I'm really looking forward to working with Jay. We have one joint project that we're working on slowly with Picari, which Dr. Steve knows about, because Dr. Steve knows the Picari. He's an old Kaiser comrade, and as is one of the members of the board. So and I've talked to Steve about what we're doing, Jay. Does anybody, before we move on to Manning, does anybody have any questions, any thought they would like to ask Dr. J before we move forward? Okay.
Steve, I just typed you a private message.
Okay. Okay. Thanks for pointing it out, because as I tried to do this with Rick a couple of months ago, I'm finding my way on this. So thanks for pointing it out. Okay.
Okay. So let's Jay, we'll be in touch. I'll be very, very interested to hear how you perceive this call, and whether it's something that maybe we can develop with you, and certainly develop a blood cancer call, which I would much like to do. Let's move on to Bill Manning. So many of you know Bill because you've read or at least you know him through the online blog that he's been posting for many years now on New Prostate Cancer International. As I wrote originally, Bill and I go back probably to around 2008 when I first was interested in trying to do something for men on long-term hormone therapy, and I saw that exercise was a really good solution, and Bill was really supportive because at the time he was doing triathlons, I should say, and raising money for prostate cancer. In doing so, at a point in time when he'd already he knew the disease had metastasized. It's really amazing sort of pain and perseverance that Bill is still with us today, and I'm really grateful. I'm really grateful to have his presence in the prostate cancer community, and I'm really grateful that finally to join us on a call, because I know that it's not his first love, but Bill came to me because he's been using for the last 6 or 7 months that he thought might be of interest to you, and wondered if the guys on this call would like to know about it. I said, of course they would. And with that, Bill, maybe you can give a quick synopsis of your disease path and talk to them about your drug, which we haven't named. So they're all, I got them all waiting with bated breath here, Bill.
Okay, thank you, Rick. First of all, condolences on the loss of your mom.
Thank
Sorry
you.
to hear that.
Thank you.
Absolutely.
So the current status of my disease, I classify it as late stage disease, extensive bone involvement, extensive lymph node involvement, multiple metastases in the liver. I'm a heavily pretreated patient. Pretty much exhausted all the standard treatments. Had a couple of different surgeries. I had salvage radiation. I've had a couple of palliative radiations. Gone through, I'm still on Lupron, just for kicks. Gone through Lupron, Zytiga, Xtandi, Xofigo, did Taxotere plus carboplatin, did cabazitaxel. So earlier this year, the beginning of 2016, I got to the point where I had failed cabazitaxel, and I also had significant peripheral neuropathy from basically in all of 2005 I was doing some kind of chemo infusions. And the neuropathy was definitely treatment limiting. And I had some scans in January, and it just wasn't great. So it really wasn't, advisable to keep doing the cabazitaxel. So I did what just about everybody's doing these days, and I had a biopsy done and did some genetic testing. There was a little bit of a mess up in that, and there was the delay. So during the delay, I actually started taking olaparib. I took that for about 6 weeks, and my chemo and my PSA shot up. It doubled from 130 to 235 or something like that. I forget, 125 to 235 in that period. So that wasn't working, and my oncologist, who's I would say has a chemotherapy preference in general, suggested taking a low dose course of a drug called Cytoxan. And Cytoxan is also known as cyclophosphamide. I think that's
Cyclophosphamide.
Good, thank you. And so I've been taking that for about 6 months, and I would say that I don't think I've had any vast improvement in my cancer, but I haven't had any big progression in my cancer. And historically, when I come off of a treatment protocol, my PSA doubles relatively quick, and I get a lot of progression on scans, and so I reached out to Rick and said, I don't really see a lot of people using Cytoxan in the community. I monitor a couple of the different websites, and there's been some modest studies done, I think 2 or 3, and not large studies, but there is some benefit to some patients. Certainly not a cure, but some people do have some benefit from it. So I thought I'd just throw it out there to the group and let you guys know about that, and because I know a lot of people worry about what happens after chemotherapy, and of course there's clinical trials and things, but with a lot of disease burden, I think it's sometimes helpful to have something that may stay the course for a bit.
Bill, how do you spell that?
I'm sorry?
How do you spell
Cytoxan?
Yeah.
Cytoxan. Cytoxan? Right. Yeah.
Okay. Very good. Thank you.
You're welcome. I have a side note for you guys, because I think a lot of you guys, I'm sure maybe all of you know Dominic. God rest his soul. But interestingly enough, Dominic and I were operated on by the same doctor at the same hospital on the same day, and we were both exactly the same age, I mean within 2 weeks, and we had pretty much exactly the same outcome, pathologically and pretty much disease progression. We tracked pretty well along the years. I didn't know Dominic at the time, but obviously I got to know him over the past few years.
So, Bill, can I ask you a question? When you did the gene sequencing, did it point you towards Cytoxan in any way, or was this just sort of shooting from the hip when you started?
Shooting from the hip. I had actually no actionable mutations.
I see.
Was it a one-time dose, or are you going to be on a protocol?
No, I've been on it for 6 months. It's 3 weeks on and 1 week off. So you take 2 tablets every day for 3 weeks, and then you're off for a week.
Okay.
Side effects, I would say gastrointestinal. Hard at this point for me to sort of differentiate what's causing what side effects, but I think there's definitely some GI issues related to it. I've got a decent amount of bone pain, and I would call it a significant amount of fatigue. Blood counts are not great, but they're not like really bad. They're just sort of off. I mean, I said my CB. Anyway, you get the idea.
I have a couple of questions for you, Bill. First of all, the sample that they took for your gene sequencing, was that a recent sample or was that an old sample?
Twisted story, but no, we went into the liver and took a sample. The sample tested positive for prostate cancer, but unfortunately, it was a little too small to do the genetic testing. So the genetic testing was actually done in 2013. I went to the Mayo Clinic and had salvage extended lymph node surgery, and they used the tissue from that for the genetic testing.
So, one thing that you may want to consider, and Dr. Steve has been looking at this too, is a liquid biopsy, where the analysis of the DNA, what they call SNPs, is done. The downside is that the panel is smaller, although it still contains most of the actionable genes we know about. It can be done by Foundation One, or it's actually Foundation Act, which is a subsidiary of Foundation Medicine. I don't think that I think that they backcharge the pharmaceuticals. Steve may know a little more about that. But I'm a strong proponent that men who do get genetic sampling, genomic sampling, need to do it with samples.
Yeah, let me just speak to that briefly. So I just had blood tests for the Foundation ACT done this morning, so I obviously don't have the results. But the panel, the gene sequencing panel they do is pretty comprehensive. They look at, I think it's 60 or more specific mutations. The good side of it is it's not circulating tumor cells, CTCs. It's actually circulating DNA. ACT stands for Assay of Circulating Tumor DNA. And so it's a new technology. It's been available about 4 months. And interestingly, I go to Kaiser Permanente in Northern California, and so far I ordered it, and I got a FedEx package with the tubes ready to go and pre-labeled, and I just had the lab draw it, and they sent it off same day FedEx, and that was that. I think the cost is about $5,800, but like Rick is saying, Foundation Medicine is right now in a sort of interim period where they do ask for your income and so on, and they do actually bill your insurance, but if it's refused on insurance billing, they generally don't go after you for anything. So so I think it's a simple test. If you hadn't had gene sequencing done, it's not as comprehensive, obviously, as a full panel, but it's reasonably comprehensive. The consistency between this and tissue is very, very good. So it enables you to do, you can do 10 cc's of blood and you got it done. So you could have it done repeatedly as the disease progresses or continues. So I do think it's worth looking at.
Richard and Steve, a quick question on that. I listened to your YouTube recording that you had. I think it was in Chicago. It wasn't Chicago, but it was just recently.
Right.
And on there, you asked the question about gene sequencing and things like that, and the doctors were very evasive about it because they really don't know what to do with it. And this was in terms of ARP. And boy, a little chemo brain here. ARP chemicals or ARP medicine inhibitors. I'm sorry, ARP inhibitors.
ARP inhibitors. Yeah.
ARP inhibitors.
So what is the purpose of getting this gene sequencing if they can't do anything with it?
Go ahead.
I don't think they can't do anything with it. I think the question is, are they willing to, first of all, order the test, and then are they willing to act on the test? And that's up to your individual medical oncologist. It's not a, if they find something that's, there's a match in terms of treatment protocols, they certainly can act on it. So I'm not sure exactly what you mean by they can't do anything with it. It's their option to order. The big thing is getting the test ordered because it's quite expensive. Okay. And so your oncologist may say, no, it's experimental, it's not standard of care, and therefore we're not going to order it. That's, I think, the bigger deal.
Okay, I'll talk to him about it and see.
Well, here's the other side of the coin, which are the results, Albert. It's difficult sometimes. Not only do the docs not really know about the tests because it is cutting edge, but also they don't know how to interpret the results, and that can be embarrassing. Now, we're lucky enough to have some resources that are available to the guys on this call of medical professionals who can interpret the results. Phil Burhans, who, as you know, is well, you may not know, but you might have been on calls with him. You've heard him if you've listened to some of the old calls, is a cancer research professor at Roswell Park who's been researching these BRCA pathways and other genomic pathways for his whole career, and he's offered to interpret the disease. He's on olaparib, by the way, and he's benefiting from it. And in addition, I have access to the senior research vice president at Clovis Technology, which is another company making some cutting-edge drugs, PARP inhibitors and more. And he's also said that he would interpret the results. So if you get the test done, we can work with your doctor to help them interpret if they're willing to work with us. Now, if they find that there is something called an actionable gene, which essentially means a gene that we know will respond to a drug that is out there that probably has not been approved for prostate cancer but may have been approved for other cancers, then we have to figure out how you're going to get that drug. And that's what we did with Trevor Doherty, God rest his soul, but it took us so long that he didn't have a chance to figure out whether the drug that that was found to be suitable for him, Keytruda or pembrolizumab, would work or it wouldn't work. So I encourage people to try and get their tumor sequenced earlier rather than later, and that gives us plenty of time, and then we can hold your hand and walk you through the process.
Okay, I might take you up on that. I've got to start chemo again in another week or so. But I've got to see the doctor next Monday, so I'll talk to him then.
So, Albert, let's come back to you when we talk around, because there are some issues I would like to discuss. But I want to go back to Bill Manning. Bill, question for you: did you do the chemotherapy trial that Dom did right after your surgery?
I did when I first time I went on ADT was in January of 2008. Mm-hmm. I had surgery in December 2005. I had salvage radiation March 2006, April 2006, and then it just took it took 18 months without doing any treatment. Did a whole bunch of triathlons. Did an Ironman. Did all my favorite races. Yeah. Did very well, by the way. Yeah. Cool. And then, because my PSA wasn't too bad, but by January 2008, it was time to do something. So we combined the ADT. I did 7 cycles of Taxotere along with the ADT. Mm-hmm. And I did ADT for about 13, 14 months. And then came off, and by September 2009, which is about 8 or 9 months later, PSA was back, and then back on IADT in January of 2010.
Okay, the reason, what I was really wondering was, Dom did an early trial of docetaxel as an adjuvant therapy right after his surgery, because I guess he had positive margins. And I don't know that the results of that trial have been published fully yet, but it's always been a thought of mine that possibly that may have extended his survival. Of course, there's no way of knowing, but it may have done so.
Yeah, I actually was offered to be in that trial, and I elected to just do the treatment off-label.
Uh-huh. Mm-hmm. Mm-hmm.
So, Bill, this is Steve. Can I just ask you, I mean, I'd like to think it's your triathlons and other, healthy lifestyle or whatever you've done, but what do you attribute, here we are, what is it, 11 years now after stage 4 diagnosis? Is that what I'm hearing?
I was stage 3 TB with 1 positive lymph node. So it's 3 TB N1.
Diagnosis, but you've had bone metastasis since then, you said, right?
Oh, I've got tons of them.
And liver, visceral. So I mean, what do you think? I mean, what if you had to look back at this? I mean, all the treatments you've had. Any words of wisdom for the rest of us that are kind of looking at this?
Well, I think what I tried to be was sort of aggressive in my approach. I mean, that's why I did the early chemo with the ADT, and then it became sort of I think the game that we played was try and stay healthy enough for the cure, because back in 2006 timeframe,
Yeah.
The oncologists, at least at Sloan Kettering, were telling me, oh, it's 5 years, it's 5 years. It's going to be, I mean, I had Dr. Scheer tell me point blank Xtandi was going to be the cure. But it wasn't called Xtandi in those days. It was called MDV 3100.
Right.
But, I tried to take advantage of, what was out there, to be more aggressive as opposed to less aggressive. I had salvage radiation when they told me it wasn't going to work. I did the chemo. In 2013, I went and had the salvage lymph node surgery, and that was a really high-risk thing. But I was just trying to get as much of the cancer out of me as I could. I don't have any regrets. I wish some of the newer stuff was available earlier because, I'm with Rick. I believe that the earlier you intervene in these things, the more effective it'll be. My personal sort of feeling is that ultimately this disease is going to be controlled much better by the early use of genetic testing in combination with probably hormonal and immunotherapy. And I think that's sort of, ultimately where, guys like me, maybe they can knock it out before the tumor burden gets too heavy. So anyway, but no, I mean, I think, I mean, one of the things that I look back on and say, when I was diagnosed, it was the result of a physical, and I was like 48 years old, and I just went to this doctor to get a physical, and after the physical, he looked at me and he said, "You got the body of a 30-year-old." He goes, "Your blood pressure is perfect, everything's perfect." And I left, and about a month later, 3 weeks later, I got a note in the mail saying, "Oh, by the way, your PSA is a little high. You may want to check it out with the urologist." And I had a DRE during he didn't feel anything, but I went to Sloan pretty much right after that, and they felt it, and then they did the biopsy, and it was 10 out of 12, a lot of high grade, 4+4, there was some tertiary 5. My surgery was high risk. I mean, there's no question about it.
Okay. Anyone else would like to pose questions to Bill? No?
Yeah, Rick. Bill, this is Bill Franklin. So did I understand you right? Did you actually run triathlons or do marathons while on ADT, or you took a break?
No, I did them actually on. Yes, I actually did the Lake Placid Ironman while on ADT.
Lupron, or?
Yeah.
Well, I don't know how you did it, because I
Well, it was very, I mean, I don't want to bore you guys with this stuff, and I don't want to toot my own horn, but it was, when I started training for it, I thought there was absolutely no way I could do it. I mean, just, and then it became sort of a mind over matter game. And then, actually my training got to be pretty, I wouldn't call it good, because, I mean, my performance, when I was healthy, I was what we call a competitive age group triathlete, which meant that I trained really hard, but I wasn't really necessarily a great athlete. But, if the really good athletes in my age group didn't show up, then I could get into the top 3. There was a couple of guys who were really good athletes, but I would run 6-minute miles. I run 10K in under 42. Run a 5K in something around 18 something, maybe a little better on a good day. So I started training for this in 2011. It's a longer story than that, but it's too long. But it was really difficult. And but then I got to the point where I was slow, but I could kind of do this stuff if I really pushed myself. Right. And then a very unforeseen thing happened. And I have my theory about this is, before an actual race, you get a little nervous and you get some adrenaline flow. Before an Ironman, you get really nervous and you get a tremendous amount of adrenaline flow. And so when you take somebody who's castrate and who doesn't have any androgens, and your body starts to pour in a whole bunch of adrenaline into your muscles, it created a very bad combination. And I had extensive cramping on the 15 and a half hours that it took me to finish that stupid race, which is kind of an embarrassing time to talk about, but finishing it was a pretty good accomplishment.
That's an awesome feat. There was a question last week or a couple of weeks ago that someone else asked when Rick, I think when you brought up that exercise program, Rick, or it might have been previous to that, that I've noticed myself. I was in fairly good shape, but after surgery and some other things, I gained about 20 pounds. But even on ADT, you make physical gains. Some people say, you know, I'm trying to work out, I don't get anything out of it, except maybe a little energy boost, but you actually make gains. You know, you do more reps, you can do more weight, you can. It's not like when you're not on ADT, of course, but you do make gains. So
I agree with that.
Yeah,
I mean, you struggle, and my performance was dismal compared to what it was not on ADT, but yeah, I mean, I definitely could make some progress.
The gains come harder, right? More pain for the more gain.
Yeah, a lot more work for much less result.
Right. But results nonetheless. It backs up a lot of what Rick has said about exercise. So.
Yeah, I think the reason that I'm still, I mean, I look at my bone scans and my MRIs, and I go like, how am I walking? I mean, it just doesn't make any sense, but I am. I'm fairly mobile. I mean, I have pain, but I mean, I get around pretty well.
well, I mean, I think it's pretty amazing, and to you, and let you be an example to all the guys on the call who do struggle with their exercise, and you should be an inspiration. They should think of you and know that they're not alone in what they're trying to do, and it can be done. And you know, God bless you. I mean, and I don't want to leave Dr. Steve out of all this, because Dr. Steve won a tennis tournament after his fifth docetaxel infusion.
No,
Is that right, Steve?
I did. I went up to tennis tournament down in Palm Springs, but that was when I was on Taxotere. Since I've been off the chemo, my game's gone to shit, I must tell you.
I think we need some sort of a competition between Bill Manning and Dr. Steve. I don't know, guys. What do you think?
Yeah, I'm not ready. I ran 3 marathons in my life, which is probably why my spine looks so bad right now, but I've never run a triathlon, that's for sure.
All right, guys. Anything else for Bill before we check in with everybody?
All right. Well, thanks for having me, Rick.
It's a pleasure, and it's really a pleasure. And anytime you want to come on, we'd love to have you. And please hang in, listen, and if you feel like contributing, or if you gotta go, you gotta go. But you are.
Oh no, I'll stay on and listen.
Thank you.
Thank you, Bill. This is really very, very helpful.
Thanks.
You're welcome.
So I've taken my headphones off because my mic was not working. I got to check it out afterwards. So hopefully you can hear me just fine. So I'm going to just run down the list again just to make sure. I think we may have a couple of people that have joined us since we started. So I'll read everybody's name. If you don't hear your name, then please shout at the end. And if you could mute when you're not talking, that would help us just a little bit too. So we've got Eric Bookbinder, Albert Basile, Bill Franklin, Bill Manning, Jake Hannum, Jeff Ledoux, Jim Harrington, Len Sierra, Peter Kafka, Frank Kelly, Dennis Correa, Jim Cameron, Steve Bornstein, Jay Burton, Rich Catapano, Mike Tamales, and Jay Burton. No, Jay Burton twice. Anybody else?
Yeah, Paul Frieda checked in late.
Hi, Paul Frieda. How are you?
Okay.
Anyone else? Okay. So I'm going to just run down now and ask everybody. Well, I'm actually going to do one thing before I do that, because I know that Peter Kafka is going to be leaving, and I just want to spend a little bit of time with Mike Tamales whilst Peter is on the phone, because I know Mike has a doctor's appointment, and we we just want to give you some encouragement for this appointment tomorrow, Mike. Are you with us?
I'm here.
Okay. And Peter, are you still with us?
Yes, I am.
Okay. So, Mike, as we said last Tuesday, when we were at PCRI, we raised your situation with a number of fairly eminent doctors. And we also spoke to the guys at Dendreon about your suitability for Provenge. And, you know, it was, as I think Peter's already communicated to you, the fact that you're doing Xofigo, the fact that you're on pain meds, and the fact that you were sick a couple of weeks ago when your doctor scheduled you would all exclude you from Provenge. And I don't think it hurts to let your doc know that tomorrow when you see him, you're aware of that. Secondly, there were a couple of doctors who felt that that they would be willing to work with you if you could find somebody else on the island to work with, or on one of the Hawaiian islands to work with. Jeff Turner, who is Peter's doc, seemed to think there may even be somebody local, but he wasn't sure, and he said he'd get back to us. But I do think it's really important that that you assert yourself in this meeting with your doctor tomorrow, and you get him on the same page as you, or you find another doctor, because his recommendation that you go do Provenge when you weren't fit for it could have had significant impact. And God bless Peter for doing the research and talking you out of it, just on the basis of those drugs. So when you go in tomorrow, just advocate for yourself and stand up for yourself. And, you know, we're not going to leave you hanging out here. We've got doctors who are happy to work with you, and we're going to find a solution, and we're going to get you the sort of treatment that you should be getting. Peter, do you want to add anything to that?
No, Mike, we're going to go in with some a note that you can sign as though it comes from you, with some outlining, you know, what our requests are. We're going to put it in writing.
Sorry, what about that?
We're going to put our request to Altaha in writing.
Okay.
Could you explain that a little bit to me? You're going to put some requests in writing as if it came from him?
No, to him.
To the doctor from Mike Gonzalez.
I see. Yeah. Okay. And who's going to be the author of that note, those requests?
Mike and I.
Okay.
Okay. So, you know, I think that's probably a smart way to go. So at least there's a record. You know, we may not change his mind. We may not change his mind that chemotherapy. Look, you're not a candidate for chemotherapy now anyway, because you're doing the Xofigo. But you know, we don't want him saying that chemotherapy is only used in a palliative situation, which is what he's been telling you. And because maybe if your bloods are good, you may be a candidate for chemotherapy when you finish the Xofigo, Mike.
Yeah. Just a comment, and I don't know the relationship you have with your oncologist there, but it seems a little adversarial to go in there with a document that says, you know, these are the things I want, rather than as just a simple discussion. These are the things. I belong to a support group. Some of the people have suggested these things. When you hand someone a doctor a piece of paper, it's a little adversarial, quite frankly, and I'd be a little cautious about that. Okay. And I'm speaking of who's gotten a lot of paper over the years.
The problem, I totally agree with that.
Yeah, I know you do, Mike, but here's the problem. That you've had the discussions with him, the way that Steve is recommending is what we've done in your last several visits. with Peter to the doctor.
Yeah.
We've had the discussions about, are you suitable for chemotherapy, and can you get gene sequencing, and and shouldn't you be using a more recent tumor sample than one that's 6 years old? And we've discussed it with him many times. And
so what's his response been, though?
It's negative every time.
But then I think rather than giving him a piece of paper that says this is what we think you should do, which is sort of an adversarial ultimatum, like, I just switched doctors. I would just go to another doctor at that point.
But
why are you trying to get into an adversarial conversation?
Steve, it's not that easy, because we don't know where the alternative doctor is on Maui.
Well, it has to be a doctor on Maui, right? That's one of the stipulations. It has to be somebody on Maui, not even in Honolulu.
Well, this is what we're discussing, and this is what we're trying to locate.
It may go fine. It may go fine. He may say, "Oh my God, I've seen the light. I'm going to start reading some modern textbooks and some journals, and I'm going to change my philosophy on how I treat my patients." I don't think that's going to happen, quite frankly. So I think I would just be kind of looking around for someone else to take care of me. I mean, that's just the way I would approach it, rather than being adversarial, because this guy is probably not going to react well to this.
Well, you see, the other side of that coin is that if you don't have a paper trail, then there's nothing to come back on. And we've asked and asked and asked, and you're right, he may not listen to us. But there has to be a paper trail. That's my opinion. I mean, I think we've gone the gentle route for the longest time, and Mike is not getting proper care.
No, I think we all agree that the care is not state of the art. But when you say paper trail, you're sounding a little adversarial, Rick. You're sounding like you're going to sue this guy if it's a bad outcome. I think you should abandon ship here. I mean, that's what I would do. I wouldn't try to get into a pissing contest with them at this point. You've already discussed it with him. He said no. I mean, I don't know. I mean, I'm not saying don't do it. I'm just saying it may go south on you.
My experience, this is Bill Manning speaking, my experience has been that when you get into an adversarial relationship with a doctor like that, I agree with Steve, it's basically over. And you need, if you hand him a piece of paper, at least have a plan B, because if he says I'm not going to do it, or if he gets huffy about it, you need treatment. You need a plan B. I mean, I had this situation with a doctor in Sloan Kettering, Howard Shear, who's supposedly the best oncologist in the world, according to him, and I couldn't reconcile his attitude with my desire to be treated differently, and I found a doctor who had a different sort of attitude. And I think it's imperative. I mean, you can't force these oncologists to do what they don't want to do. I don't believe. I mean, that's my opinion. Doesn't mean it's right. I mean, that's just my experience.
I'm going to offer a different perspective. That is, I think that really depends on where you are. And that means, I'm in the Springfield, Massachusetts area. I'm 90 miles west of Boston. I'm about 2 hours and 15 minutes north of New York. I've had a load of patients with that many prostate cancer. And I can say that I don't recall any of my prostate cancer patients having genetic testing. And I've been in practice for 28 years. And so, and I haven't seen any of our oncologists or even patients who've gone to Dana-Farber, which is the closest major center to us, have genetic testing and therefore treatment based on that. So I think that it really depends on where you are. I want to go back to way back in the beginning what Albert was saying, how is this all going to change my treatment? And I really think that's part of it. I think that there are a lot of, and Maui may not be the same as, inner city San Francisco or Boston or New York in terms of the sophistication of the treatment. But then, again, whenever I order a test, I say, how am I going to use this? So if in Maui, they don't have the ability to tailor their treatments based on genetic testing, then going back to the discussion about adversarial relationships with the doctor, that doesn't matter if they don't have the ability to do that on Maui. And so, you know, I think that it's all about perspective and what the particular area that you're in allows you to do medically. And I think that if the bottom line is if you're not happy with your current situation and your care, you always have the right to seek out another physician. And if it's not on Maui, then it needs to be somewhere else. And maybe the focus should be on where you think you can get an alternative care that makes you feel like you're being cared for.
So let me just add a piece of information, Jay, that you don't have, which is that we broached this genomic testing with the oncologist. And he was very positive because there's actually some sort of a trial or a funded program going on Maui right now. And the guy said, sure, of course we can do it. But then when we came to talk about samples, the doctor wanted to send off a sample from 2011. Mm-hmm. And so, again, you know, it isn't that he's not receptive to genomic sampling, but he just hasn't done any reading or doesn't have an understanding of it and doesn't realize that the likelihood is that with advanced prostate cancer, it may have morphed over the last 5 years, and that testing for 2011 isn't going to show the same as testing if they took a more recent sample, even if they just took the ACT sample, the SNPs, the DNA SNPs, the circulating tumor SNPs. So on the one hand, I agree with you. On the other hand, I think that we've borne this in mind, and I think that if we found an actionable gene for Mike, we could then work to try and get him the right drug. My concern is that this particular doctor, and incidentally, this isn't the first time, the doctor has somewhat of a reputation, it turns out. It's just not, he's not providing Mike with the best possible treatment.
So Rick, again, I hate to belabor this. The last thing I think we should do as a support group is to undermine the relationship any of us have with our doctors. But if this guy has a reputation, the thing to do is not to go in there and try to change him in some way. That's not going to happen. Certainly not by becoming an adversary and saying, these are the things that I really feel you should have suggested already. The thing to do is to report him to the local medical board and say the standard of care is not the standard of care right now. And I think that's the way to go if you really have those concerns. And like I said, I would have long since punted and gone see another doctor, even if it means flying to Honolulu, which can't, you know, I mean, it's not that far. There's got to be some reputable and competent doctors in GU Medical Oncology in Honolulu. It's just got to be.
Okay. Well, Peter and Mike, you know, maybe we can talk a little bit later then and decide how to handle this appointment tomorrow.
Let me just respond to the last comment. There are no GU medical oncologists on Oahu. We'd have to go to California.
Okay. Yeah. Well, you know, like Jay was saying, the care is highly dependent on the doctors that you're able to see, and just because you live in Hawaii doesn't mean you want to get care that is sort of 10 years old in its vintage. I think, you know, I hate to say this, but, you know, this is a serious disease, and you want to get the best care you can.
Right. Well, last year, the end of last year, they got their first multi-parametric MRI machine in the islands, and there's one over at Queens Hospital on Oahu. That's for everybody.
No, I practiced medicine for 3 months on Oahu once. I did a lot of deliveries on Oahu and Honolulu, believe me, and you know, it was a long time ago, but it was different than California even back then.
Right.
Okay. Well, it's been good advice, and I'm glad that we're bouncing this around in a larger group, and Peter and Mike, you're hearing from two other physicians who are on the call, so it's definitely good advice. Yeah.
Rick, has anybody suggested the possibility of a nice Skype call with someone at San Francisco?
Absolutely.
Well,
yes, we're looking.
And normally they don't do that, but I mean, in this case, they might make an exception and be happy to meet with him for a half hour on Skype, and then then now he's talking to the best.
Well,
yes, my doctor in Marina Del Rey has suggested this, and we're going to look at it.
Yeah, I mean, Jeff Turner has offered to participate if the guy's willing, but we talked to him before, and he doesn't. I think we've raised this before about talking to somebody else, and he hasn't been open to it. But we'll broach that again.
So are you talking about your doctor in Maui having a second opinion, either Skype or video conference or telephone call from somebody else, like a virtual consult, or are you talking about the patients themselves, the people that are getting the care here, talking to somebody else as a second opinion? Because those are two very different.
I'm talking about the patients themselves. I'm not talking about doctor to doctor.
Yeah, okay, that's what I thought, Peter. And I think that's an excellent idea. You can, Cleveland Clinic has made a fortune basically on virtual consultations around cardiac disease, right? I mean, people. So I do think that if you could set up some sort of virtual consultation, at least you could really advise some other people and see what they would suggest.
Yeah, but
I think that's helpful.
There are two issues here. I mean, one is, yes, we've definitely spoken to Jeff Turner in Marina Del Rey about consulting with Mike Tamales. He's happy to do it. But the other issue is we have to have somebody local who can implement for Mike. There's got to be a local person, because Mike can't be flying backwards and forwards, and if Turner wants to prescribe something, there's got to be somebody local who can help to administer and to monitor. So one of the things we've talked about before is the local doctor working with somebody with some expertise on the mainland, and Turner has said that he works with people in Hawaii. So ideally, we've got to create somebody who could administer local treatment for Mike. We can't just put Mike in a situation where Jeff Turner says, well, we do this, 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 and this, and then there's nobody to execute.
Yeah, I think the way you have to couch this then is to convince your doctor in Maui that this is an opportunity for him to work with an expert in this area and learn something himself. I mean, I just think he has to let go of his ego enough to be able to say, I'm willing to work with this doctor, and this is an opportunity for me to maybe learn something as well. So, and that's really highly dependent on ego, I think.
Okay. So Peter, maybe you can give me a call later on tonight, huh?
I'll try. I'll do my best.
Thank you. All right, Mike, and good luck tomorrow, whatever happens.
I'd like to add something to this discussion a little bit and go back a little ways about the genetic testing.
Go ahead, Frank.
My wife I came back, no actionable genes, and my wife did a little research on it. This test is not a magic bullet.
Right.
I can't remember the percentages, but something like only 17 or 20% of men, I think it was 17, come back with an actionable gene. And of that 17% that they find something that's supposed to work on it, only like 2 or 3% it actually works on. So it may be identifying something for some of us, but it's not really throwing something out there that you can chew on.
Yeah. No, I think that's an excellent point. I think we tend to look at this as, this is the solution here, and you're absolutely right. But the other thing to look at is, especially as you look at checkpoint inhibitors and some of the newer research being done, it doesn't mean 6 months or a year from now they're not going to discover something actionable, and then you have that result in your pocket.
Yeah, you know, for those of you who listen to Larry Fong's discussion of immunotherapy for prostate cancer a few weeks ago, and it is linked on the ANCAM website. If you haven't, I recommend you all do. And he was very clear about that point, that only about somewhere between, he said somewhere between 10 and 30% of men have actionable genes. And of that, you know, somewhere around 10 to 20% may respond to the drug. So when you boil all that down, it's not many people. But the bottom line is that for those people where they do respond, it's huge. And it doesn't cost very much, nor is it very painful, nor are there too many side effects, at least to determining if you have an actionable gene. I mean, there may well be side effects to the drug. You know, I just was with a good buddy who has advanced lung cancer, who stopped responding to, he's HER2 positive, he stopped responding to Herceptin, and they just switched him on to Keytruda, pembrolizumab, in the hope that it's going to keep his cancer at bay. And yeah, he feels the fatigue. He's feeling the drug, but he just got almost a year out of Herceptin. So yes, I can't disagree with you, Frank, that it's only a small number of people that are going to benefit, but you may be one of those people. How old was the sample they analyzed for you, Frank? They did a blood sample, did they not?
Yeah, it was a fresh one.
Okay.
It just went out 4 weeks ago, and
Okay.
we just got our results back.
Okay, and the results said there were no actionable genes?
Yep.
Okay.
And we tried to do the biopsy, and they missed the biopsy, and blah, blah, blah. So
You know, the other thing is that doesn't mean to say that in another few months you might not have, you know, do the test again, because there may be an actionable gene, because this is a dynamic process. And, you know, one thing that does occur to me, that Jay, something that Jay raised earlier, about the fact that some of this testing is not standard of care, and there are many doctors who aren't using it yet. And absolutely, that's absolutely correct. I was listening to the Cancer Care presentation on metastatic prostate cancer that was given 2 weeks ago. I was listening to it this morning. And Susan Slovin, who is a medical oncologist at Sloan Kettering, and supposedly state-of-the-art facility and a state-of-the-art doctor, publicly said that the ARV7 test is not available publicly, and that it's a very rare mutation. Well, it isn't rare. About 35% of men have ARV7, are positive for ARV7, and it is publicly available. Johns Hopkins has made it publicly available since the spring. So, you know, but you know, I understand that, as she later said, it's very hard for the docs to keep up on everything, and it is, and so we have to understand that and be empathetic. But it doesn't mean to say that if we don't hear of something and we disseminate it, that you shouldn't be going to your doctor and talking to them about that treatment or that test.
Can I add one more thing about genetic testing? And I don't know if they can do this in the when they use the blood sample, but one of the important things to me, and it was actually more important than actual gene, is I wanted to make sure that I didn't have germline, you know, BRCA that I would be passing on to my 2 daughters, and I thought it was my duty as a dad to find out if I did have, you know, some kind of, you know, germline, mutation that my kids had to be aware of.
Absolutely. Peter Kafka, are you still with us? You want to say something about that? I think we lost Peter, but yeah, Peter just did exactly the same thing. I mean, Peter isn't at a stage where he necessarily needs genomic testing, but he just got tested because he's got significant history in his family, and he wanted to be sure that he wasn't passing it on. So I absolutely agree. He did just a simple germline test rather than the more complicated somatic test. But I absolutely agree with you, Bill. Okay. So let me run down this list and see who has something they'd like to raise tonight. Eric, anything for you? Mr. Bookbinder, no, nothing. Okay, I'm getting hand signals. Okay, Albert, let's just come back to you about this chemo that you're going to be going through again in a week or so. Bill Franklin, anything for you?
No, I'm good tonight, Rick.
Okay. Jake, anything for you? Jake?
No.
No, thanks.
Thank you, Rick.
Jeff Ledoux, anything for you? Jeff? Okay. Jim Harrington, anything for you?
No, not tonight, Rick.
Thanks. Len, anything? Oh yeah, Len, if we've got some time, maybe you can take us through the Morris presentation.
I could do that, yes.
Thank you. Peter Kafka, I think, has left. Frank Kelly, anything for you?
Yeah, I'd like to talk a little bit about bipolar treatment.
Absolutely. Yeah, I'm sorry. I should have raised that. You let me know ahead of time. I apologize. Dennis Correa, anything for you?
No, nothing.
Thanks. Jim Cameron, how about yourself?
Nothing tonight, Rick.
Thanks. Dr. Steve, anything for you?
No, I'm about to start radium tomorrow, so I'll maybe talk a little about that next month or so.
Okay. Okay. Well, the Xofigo guys are looking for a brand ambassador, Dr. Steve.
Yeah, they'd have to pay a lot of money, Rick.
Okay, I'll tell him. I'm speaking to him tomorrow. I'll tell him.
All right.
Rich Catapano, anything for you? Rich, are you still with us? Okay. Paul Frieda, anything for you?
Nothing tonight, thanks.
Okay. Have I missed anybody?
Rick, this is Jake. I will have one comment on metformin we discussed last week.
Okay. I'll come back. We'll come to you.
Okay.
So Albert, let's start with you, and you are going to start chemo again tomorrow. Give us just give us a quick update on what's happened since your last chemo and
Okay. Yeah, with I had Doxetel, and I had, I believe, maybe 4 months of it, 5, something like that. I have to look at my records. PSA continued to rise. The doctor pulled me off of that, put me on Zytiga with prednisone, and also the 233, the
Xofigo.
Exchivo.
Xofigo.
Excuse me, gentlemen.
What Steve is starting tomorrow.
Yeah. So even with that, the PSAs continue to rise. Matter of fact, they rose even quicker on that regime. And so he said, let's go to chemo. He's a competent doctor, explained, and he felt it was a little bit on the aggressive side. I raised the question, is this going to work any better than the chemo before? And he said, well, you know, the chemo works best with fast dividing cells, and yours seem to be doing that now, so maybe it'll help. It's worth a try. You know, if not, then we'll go on to try something else.
Okay, when excuse me, what's your PSA been doing? Tell us a little bit about that.
Oh, okay, last year, I think around January timeframe, it was like 0.02. Then it went 0.04. Up until April or May, it was, let's see, maybe 40 or something like that. Then it slowly made up to 60. 1 month, the month before last, it went up only 9 points. Then I started, that's when I started the regime, about halfway through. After that, it went to, I believe, 130 from 70 or 80. And this last one was 230.
So Albert, how long were you on the abiraterone and the prednisone? How long were you on?
Just about 2 months. That's all.
2 months.
I'm sorry. I had three treatments with the.
So that's the Xofigo.
Whatever you call it.
Yeah, radium-223. But the abiraterone, you were on for how long?
The same amount of time, maybe 2 weeks before.
So about 3 months, give or take, 12 weeks.
Yeah, 3 months, give or take a couple months.
And the Xofigo, you had 3 treatments, and then you decided to abandon the balance?
No, I didn't decide. It's what do you do when your PSA is doubling almost on a monthly basis?
Well,
you know, and so we may go back to it, but we can't have the Xofigo and chemo at the same time because of the blood count issue.
Right. What was the alk-phos doing? Did they tell you?
Pardon?
The alkaline phosphatase?
Yeah, let's see. The last time it was high, not that terribly high. I'm not sure what it was this time.
Did it come down with the Xofigo, though?
No, it actually went, once I started taking Xofigo, it went up. It was normal before, and then it went up.
Yeah.
So I assumed with that the Xofigo was working. Because, you know, that's a normal thing. But, you know, I'm going to have, I'm actually a week or so away from the chemo. Next week, he wants to go ahead Thursday and have MRI scans and CAT scans. So, and then we'll review the results Monday.
And what chemotherapy is he going to put you on? Is it cabazitaxel this time, Jeff Tanner?
Yeah, that sounds about right.
What I don't know, and maybe Dr. Steve does because he's researched this a little bit, is I don't know how effective Xofigo is if you interrupt it and then restart it.
I don't either. Yeah. I do think, though, that if you're on 12 weeks of abiraterone and failed, I think it's wise to move on to something else here. For sure. And you can't take chemo and Xofigo together, so you really have no choice. You know, you're kind of left with stopping the radium, even though it may or may not be helping. The PSA on radium notoriously can go up on radium in spite of the fact that your alk-phos is going down. So the PSA...
Yeah, I've heard that, you know.
Yeah, but if you took 12 weeks of abiraterone and your PSA has gone up that high, I agree. I think it's wise to move to a different path here.
Okay, thank you. Yeah, those, I think I'm starting to get really castration resistant, if that's the best term I could think of.
Yeah.
You are, for sure you are. If you've been on, I assume you've been on ADT this whole time, right?
About 3 years.
Lupron.
And I had the Xtandi, and I forget, biclutamate, I believe. So I had those, and then the Xtandi, and then the chemo. So.
But you've been on Lupron or some other.
Yeah, from day one.
Yeah, so, by definition, you're castrate resistant because the PSA is going up in the presence of Lupron.
Right.
Yeah.
Right.
Okay.
Yeah, it's a toughie, and I agree with Steve. I mean, I think that probably the docetaxel, the chemotherapy is clearly a good move. Have you been sequenced yet or not? Have you discussed gene sequencing?
No, I discussed it with my initial doctor last year, and he said he didn't know how to do it. Now, I will discuss it with my doctor now and see. Now, I would assume that I'm in the Greenville Health System, South Carolina. It's an educational hospital. They have some really excellent people here that they might be able to know how to do it.
Well, if they don't, why don't you reach out to us? But there are several people that are doing it. Foundation Act is one, and then I'm just trying to remember their name. There are several guys, and we met with most of them when we met with 2 or 3 of them when we were down there. I don't know who's best. I don't know who does who has the best panels. They're probably all much.
Okay. Why don't I send you an email on it, Richard?
Yeah.
How would that be? And then you can respond if it's okay with you.
Yeah,
that way we don't hold up the other guys.
That's fine. That's fine. To go ahead and do that, and I'll give you 2 or 3 leads of people that we're aware are doing testing, and then you can talk to your doc, and then Bill Burhans has also offered, if they need more information, he's offered to speak with any doctor that needs more help and more information on that. He's a professor up at Roswell Park. So
okay.
Albert, 2 other things I might suggest. Rick has put up a video by Chuck Ryan on the use of abiraterone and enzalutamide. It's on the website. If you look at the link, it's Chuck Ryan, and it has a section there of when have you failed abiraterone and enzalutamide, and when should you move on to chemo. And I think what you're doing makes sense from Chuck Ryan's talk. And then the other thing I would do before you talk to your doctor about it is just go to the Foundation One website and review that, because your doctors don't have to know what they're doing. Basically, Foundation One does everything if you're going through them, and they have a great explanation of what the test is, how you get it done, and there's a section for patients, a section for physicians. So I would review that, make you familiar with the gene sequencing that Foundation One, which is a company over in Cambridge, Mass, does. It's worth reading through there. If you just Google Foundation One, you'll see it.
Okay, very good. I will, Steve. Thank you.
So thanks, Steve. It also gave me the break. So the 2 companies that I will tell you about, I'll give you the names, are Caris. Is one option. That's the option that a lot of the independent docs seem to like, especially
Caris, P-A-R-I-S?
P-A-R-I-S.
Okay.
And the other that I think might have been the first to actually use the liquid biopsy is Guardant, Guardant, Guardant 360. I think they may have actually a bigger panel than Foundation Act. They've also actually offered to talk to us, and I'm trying to set that up, and that could well happen. So, send me a note, Albert, and I will definitely respond. So,
thank you.
Before
one question before I've got to go.
Yeah.
I apologize. But Steve, maybe you can answer this. I have a friend, and I got to get him on this. He has a PSA of 12, and he's on oxycodone. Okay, he's in a lot of pain, a lot of fatigue, and everything else. I've got a 250 now, and I'm riding bike 5-6 miles a day in the morning before work. I lift weights. My fatigue is nothing, and I feel really good. So I mentioned that to the doctor, and what he said was, you really can't go by PSA. PSA is kind of a unique thing to each individual. Some cancer cells will produce very little, and some cancer cells in other individuals will produce an extensive amount of PSA. He said he's seen it as high as 20,000. Was he trying to make me feel good or what?
No, I mean, typically neuroendocrine variety of prostate cancer produces very little PSA. I mean, Rick, maybe you want to answer this, but the bottom line for me is the more poorly differentiated the cell is, the less likely it's going to mimic a normal cell by producing PSA. So a low PSA doesn't necessarily mean that the disease is not widespread. And the other thing I think is that, you know, I'm the same way. I mean, I play tennis 3 days a week, and you know, I don't have much pain at all. I row, you know, and you know, I think some people basically have pretty extensive bone disease and don't feel much pain, and others have one lesion and they can't walk. You know, I don't know why that is. I'm not really sure.
There's a gent pacing around the room who falls into that category right now. I mean, Eric, are you there? Can you hear us? There you are. Okay. So Eric has widespread disease, doesn't produce PSA, right, Mr. Bookbinder? Yeah, we can't hear you.
He doesn't produce any
That's correct.
PSA,
That's correct.
and his disease is widespread.
Yeah.
Unbelievable. Okay.
What's your?
Yeah, no, my PSA has gotten up to the highest it's ever gotten, and it's about 7. And I have, you know, half my thoracic spine has cancer involved.
Okay.
So, Albert, what is important though is that you get scanned regularly and you're monitoring that. You didn't mention scans at all, but be sure that they're scanning you regularly.
Okay, yeah, he's going to do it Thursday. So.
Okay.
Okay.
Oh.
So, guys, my wife's in Taiwan, and she's been bugging me to call her. So I apologize. Next time, I'll stay a little longer.
Okay, but one thing before you go, because I want everybody to hear this. Guys, please sign up for Amazon Smile. If you have not already chosen a charity on Amazon Smile, sign up on Amazon Smile. It means every time you spend any money on Amazon, we get a very small percentage. Answer Cancer Foundation is on there. There is absolutely no cost to you, no diminution of services. It's identical to whatever you've got. If you're on Amazon Prime, it's all the same. You just have to go to smile.amazon.com, and they'll ask you the first time you go which charity or which 501c3, and we're on there. So it's a good way of supporting us, and we'd appreciate it. Okay.
Sounds good.
So, Jake, you're up.
Guys, we'll see you. Thank you very much for all the input now.
Pleasure.
Appreciate it.
Jake, go ahead.
Oh, okay.
Yeah.
In weeks past, we had discussed metformin and the benefits of it. For some people were having problems convincing their doctor to prescribe it. There doesn't seem to be a lot of research on metformin. I'm guessing because it's a generic drug and there's probably no money involved in prescribing it. But the consensus seems to be that it is safe, even for non-diabetics. The one study that I saw, and thank you, Rick, for the links. You got me started. There was one study where we talked about the dosage, and what they did was for 44 people, they had a dosage of 1,000 milligrams twice a day, which is a pretty high dose. My wife is diabetic, and she only is on 1,000 milligrams. But that did have an effect in about 30% of the patients. They had a 12-week period with no progression at 12 weeks, and about 10% had no progression after 24 weeks. So, and you know, the bottom line is that it also seems to reduce or increase the doubling time of prostate cancer by about 24%. So I could not find anything bad about it. Everything seems to be good. It cannot hurt you. It can only help, is the conclusion I've been able to draw from that.
Thanks, Jake. Jake, what were the dosage? What was the range in dosages that you observed in the trials that were done?
I only found one that actually mentioned the dosages. The rest of them didn't mention it. They just said they had beneficial effects. These are not medical journals necessarily that Steve or might read, but just magazine summaries. But the one study that I did find, it was a phase 2 study on NCBI, I believe, and that was 44 patients had 2,000 milligrams per day.
I mean, my suggestion, I'm not a doctor, this is not medical advice, but I always say to guys, if you're going to do this, it might be smart to titrate upwards. So, start with a slightly smaller dose and then maybe 500 and then titrate up to whatever it is that you're prescribed. Even if the doc gives you 1,000 to begin with, start at 500 just in case you have any impact on your gut.
That's correct. The minimum is 500 milligrams.
Right.
And then they because of the gastrointestinal effects that it can have, they want to do it so they gradually increase you.
Right. I mean, I've actually seen metformin mentioned just recently as a drug in other cancers too. I guess because it inhibits sugar, and sugar is known to feed the cancer. So we just have to keep plugging away and asking our docs and putting pressure on them. And I know last Tuesday we had people saying they just couldn't get it. And Jim Cameron, you're going to be fighting for your metformin again tomorrow, I guess, huh?
2 o'clock tomorrow afternoon is my appointment. I'll be fighting for it.
Okay.
Just a quick comment. Let me start by saying I have been taking metformin for several months, 500 milligrams twice a day, so 1,000 milligrams daily. You're not going to find anything but anecdotal information. I mean, that's why you're not reading this in medical journals, because it's difficult to design a study where you control all the other treatments being used and then add metformin in various dosages. And then secondly, there's just no money in this. So the drug companies are not interested in doing any of the research. So you simply will not find any future studies around the use of metformin in reliable medical, controlled trials, let's say. So what you're going to do is just say, well, I'm just going to take a leap of faith here and say the drug is benign, and it is benign. I was a GP, 30-something years ago. I used to hand it out like water to all my diabetics, and it has very few side effects. It's been around forever. And the real problem is trying to talk your oncologist into saying it's not perfectly scientific like enzalutamide is, but on the other hand, there seems to be a lot of anecdotal evidence, and there's a hell of a lot of prostate cancer patients who take it. Would you be willing to prescribe it if I'm willing to take the minimal risk associated with taking it? And that's about the only thing you can do, because you're not going to find any controlled trials that say, oh, absolutely, it results in in stable prostate cancer for 24 weeks. That's absolute bullshit and nonsense. It's not controlled. You don't know what these patients were doing otherwise. So, I think it becomes an exercise in salesmanship to your oncologist, basically.
Well, Steve, isn't it also true that it has only been shown to have any effects in diabetics with prostate cancer? Non-diabetics, I'm not sure anybody has shown any benefit for them.
Len, I don't think anybody's shown any benefit from anybody quite in a scientific way. So whether you're diabetic or non-diabetic, I don't think is really important, because there is no scientific evidence to show it works in anybody. But I think there's a considerable amount of anecdotal evidence that it may have some impact. Enough for me, and I'm a scientist, right? I was trained as a scientist. I'm taking it, right? I figure, what the hell, if I'm going to die, I'm going to go out with all my guns flaring,
There was one study, Steve. It was published in PubMed. It was based on a Swiss study of 44 men, and it sounds like it was done about as scientifically as you can. But and that was one where I mentioned 36% were progression-free at 12 weeks, 9% progression-free at 24 weeks.
Yeah, yeah. Well, Jake, you need about 2,400 men to make that scientific.
Right.
You can't do a study with 40 people. So what I'm saying is, and I'm not, believe me, I am not opposed to taking it. My own gut feeling is it may improve things. In fact, I'm going to go see my own personal care physician, PCP, in a couple of weeks and beg him to put me on some Crestor as well, right? So I'm not a scientist when it comes to this, Crestor and the statins are in the same category as metformin.
Yeah.
But I'm not beyond taking them. I would definitely take it if he's willing to prescribe it.
Okay. Okay, well, Jim, Cameron, let us know how you do tomorrow.
I'll let you know on the next call. Gonna give it my best shot. I got a whole bunch of stuff written up about it, and I got all that stuff that you sent me last week. So I'm gonna go in there firing away.
Okay.
Jim, I would take the attitude that I know it's not scientifically proven, but I'm willing to take on the risks. I think there's enough evidence to suggest it might be helpful, and I would appreciate if we could just try this and be very humble about it. Don't tell your doctor what to do.
No,
I would make one other comment.
6 months ago on it.
I would make one other comment that might be helpful. The insurance companies sometimes balk at paying for medicines unless there's a study that supporting it. But metformin is so cheap that should not be a factor whatsoever. We got 90 pills for $5.12 the other day with insurance.
Yeah, it's not a money thing. It's not a money thing.
No, but that might be some doctors are hesitant to prescribe it if the insurance company won't approve it. In this case, even if they don't approve it, it's chump change.
The other thing, doctors are looked at by what are called pharmacy and therapeutics committees, and so they review this, and they'll pull up the record, especially if it's an electronic record, and pull up how many non-diabetics do you have on metformin. And if they find some doctor's a real outlier here, they're going to contact the doctor and say, why are you prescribing metformin in non-diabetics? And then the doctor is going to have to say, well, I believe there's an effect in prostate cancer, and then their pharmacy therapeutics committee is going to argue with them about it. So, it's not an easy decision for a doctor to do. Honestly, doctors are under a lot of constraints around these things. It's not like you could do, doctors are not cowboys. They can do anything they want. There are people looking at you. So that's the other thing to keep in mind.
Okay, guys, we're going to move on. Frank, you wanted to talk a little bit about bipolar testosterone therapy, correct?
Yep.
First of all, I hope that most of the people on the call know what it is, but if they don't, there has been some, there's been some long-standing advocates of offering very large doses of testosterone for men who are castrate resistant. And you might say, why on earth would we ever give testosterone that feeds the cancer to a man who has advanced disease? The theory is that when you give a large dose of testosterone, that it resensitizes the androgen receptors. And then you can take the patient off the testosterone and give them some of the hormone drugs that they may have failed in the past, and they may be effective after a high dose of testosterone. And there have been trials going on. There are trials continuing right now. I think, if I'm not mistaken, at Johns Hopkins, because I believe that Thibault is thinking of doing one of these trials with Antonakis at Johns Hopkins. And Frank asked me, because I guess, Frank, your doctor is suggesting you do this is this in a trial or in what type of situation would you be looking at this therapy?
Well, I think my wife suggested it about a year ago because she'd read about it. And I went in there last week and he said, I didn't think it would work, but I'm reading all this stuff about how it can work.
Mm-hmm.
And the way he explained it to me is that giving the huge doses of testosterone, your cancer, who has been starved for testosterone, builds up a lot of receptors. And when you flood it with testosterone, it cuts down on the receptors so that when you come back in with the Xtandi, which is what I'm doing, it can knock the hell back out of it.
Mm-hmm.
That's my understanding. I don't know.
Mm-hmm.
He's still trying to figure out how many weeks and whatever, but you got a half-life of 8.5 days on Xtandi, and my wife looked it up. You've got a half-life of about 8 days on the testosterone.
Mm-hmm.
So he's trying to figure out right now is when you drop the Xtandi, when you start the testosterone, and it was going to be something like around every 3 weeks for 3 rounds or something like that.
Mm-hmm.
So it's not just a one-time event.
Right.
So I don't, I'm not sure exactly what he's planning on doing, but he is a well-known oncologist, and he does his homework pretty well, even though he's not a prostate oncologist. I'm pretty pleased with what he's doing, and it sounds like it's worth a shot. Otherwise, I'm going from Xtandi to something else. And I've got really low PSA. I'm one of those guys that we were just talking about.
Right.
I'm not failing Xtandi, so to speak, but my nadir on Xtandi was 0.9, and for the last 3 months it's been going up. So anywhere from one month it went up 0.08. This month it went up 0.12. So he doesn't really call it a failure yet.
Mm-hmm.
But it is rising steadily, even though I'm really low PSA.
Mm-hmm. Mm-hmm.
And I'm willing to try it. I don't know if anybody else has done this. I'd like to know if you get some sexual activity out of it for 3 months or 2 months while you're on the testosterone. I mean, I just don't know that much about it. I was wondering if anybody else did.
Does anyone else on the call have anything to contribute on this bipolar testosterone protocol?
I have a question. When you're on the testosterone, do you stop ADT?
No, you don't stop the ADT.
Oh, you continue taking it. Okay.
Yeah, you just drop the anti-androgen, because it's all about the receptors and trying to cut down on the receptors of the cancer cells, so that when you flood it back with the Xtandi, they can't cope with it.
Okay. So you would continue with Lupron, for example, but you would stop Xtandi or abiraterone.
Yeah, I think it was 3 rounds at 3 weeks apiece. And there's a question of timing, because do you give up the Xtandi 8 days before you start the testosterone? Do you quit the testosterone 8 days before you start up the Xtandi? That's what he's trying to figure out now. And with such a low PSA, he's not worried about running after it real quick, but he wants to do his homework a little more. But it sounds like, I'm out of stuff to use unless it's a trial or something like that. So I don't want to drop the Xtandi while it's still keeping my PSA low. So I think it's a reasonable way of looking at it if there's been so much study done on it over the years. In fact, he apologized to my wife for not believing her that this works, and so he's obviously done his homework.
Well, I don't know that there's been so much. I mean, there's one sort of maverick doc that's been suggesting this for many, many years, who, is now getting more cred than than he's had in the past. But I think that it's sort of picked up steam in the last few months. I think University of Washington is doing a trial as well, if I'm not mistaken. Seattle Cancer Center, which is part of University of Washington. And, you know, most of these docs at the centers are happy to talk. So if your guy was to reach out to Johns Hopkins or to University of Washington, I'm sure that they would discuss it with him.
Well, he's got offices in Washington and offices in North Idaho, so I'm sure that's what I may be part of a trial. We never discussed a trial, but I may be part of a trial or something like that. And I don't see how it can hurt with such a low rising PSA. It's not like I'm going to get the testosterone and go up to a couple hundred PSA. Mine's never been a high PSA. Well, I was just wondering if anybody had experience with it. Obviously,
no, I mean, they don't. The only thing I do know is that Thibault Lincecum has been thinking about this himself for a while, and but he's in a trial right now. Trying to remember what it is, but he's in a trial. I would have to bring up his notes, but he's in a trial, and when that fails, the next thing that he's looking at is this as a possibility. He's in a trial at Georgetown. He's doing some sort of a trial at Georgetown. But he hasn't done it, and I don't know anyone else who has. You're going to be the first.
Well, I'll be the guinea pig, I guess. I don't know. I don't really have much choice, though, because then you're back to chemo, which is problems for my belly, and a lot of these other things are problems for my belly.
I think it's Antonakis, Dr. Antonakis at Hopkins, who is involved in the trial at Hopkins. That's a name that he might recognize. It's pretty well known. But I'm not sure who it is at DC. I don't know who it is at DC, at Seattle, I should say, in Washington, who is...
That ought to be University of Washington.
Yeah, it is University. It's definitely University of Washington, but I don't know who's running the trial. But I mean, if Lisa has a chance, go on clinicaltrials.gov and search for prostate cancer and testosterone and see what comes up.
Okay.
Hey, Rick, I'm looking at an article here that says the trial will have multiple recruiting sites, including one at Seattle Cancer Center Care Alliance, led by Dr. Schweitzer.
Okay, yeah, that's who's doing it. Now, what trial is that, Len?
Well, let's see. This is this was a January 2015 news from the Hutchinson Cancer Center.
That's probably where I read it. I think that's where I saw it. So there you go. So if he doesn't already know, you could tell your doc that Dr. Schweitzer is involved in a bipolar testosterone trial at Seattle Cancer Center, which is part of University of Washington.
Well, when he called up some of the stuff that he didn't understand, that was the name that came up to Dr. Schweitzer.
Okay.
I recognize that. His biggest problem is the protocols involved in order to do it right, and that's why we figured we may start in a couple of weeks once he figures out what the exact situation is to do it.
Okay. What I don't know is whether that's the same trial as the one that's going on at Hopkins, but also tell him that Antonakis is doing a trial, and you know he can call Antonakis up. These guys are pretty approachable, and they're pretty collaborative.
Well, I assume my guy's getting us out of Washington State.
Yeah, but what I'm saying is that you know, it doesn't hurt to talk to somebody like Antonakis and find out what protocol they're using.
Okay.
You know, he can talk to Schweitzer, he can talk to Antonakis, and then he can decide what he wants to do for himself.
Okay. Well, that answers my question. Nobody really knows, but
No, this is, again, this is more cutting edge stuff, Frank.
yeah. Well, the real high doses of testosterone. That's why I was wondering whether. Well, the other thing you're going to end up doing is probably going like a roller coaster. I would assume you're going to get some emotional stuff up and down as you do this, and I don't know whether it's repeatable after the first cycles or not. All he told me was my wife wasn't there, so she couldn't question him as well as she would. But he's just beginning to fold into this.
Mm-hmm.
That's why I'd say it probably came out of Washington State, because he does have an office in Washington. He's got an office in Idaho, and
Mm-hmm.
I'm sure that's where most of his information comes from. He's really well respected. He's like one of the top 10 oncologists in the country, so he's an older guy, so it takes him some time to absorb some stuff, but after a year, suddenly this is something he's seriously considering if he can figure out how to do it right.
Mm-hmm.
So,
Okay.
there we go.
Yeah, just keep us posted as you go along, and you know, if we have any more information, we'll let you know. Jim Cameron, who is it that you're seeing tomorrow at Hopkins? Jim, are you still with us? I guess not. All right, he might be seeing Antonakis tomorrow. I was going to see if we could get any information. Okay, Len, it's kind of late, I think, to start on the Morris thing. What do you think?
Yeah, we can do it another time.
Yeah, keep it in your quill, and we'll hopefully we'll be able to put it up next time when we have a little bit more time to discuss. But Len was at an US2 presentation that Mike Morris, who's a medical oncologist at Memorial Sloan Kettering, gave a couple of weeks back, or a week or so back, and so that's why I asked him to sort of share with us. He was talking largely about some of the new imaging methods. Anybody else have anything for tonight?
Throw this out for Mike Tamales and Peter Kafka, and it's something that you convinced me to do when I was having issues with my urologist and oncologist.
Yeah.
And your advice on that was very, very useful. I now have a new GU medical oncologist and a radiation oncologist, and all of us seem to be talking together for my benefit. And that's the thing that you know, when they did what they did in that group, I said, no, we're not going to play this game. I'm going to go somewhere else and find someone else that'll work with me. And that's what has happened.
I think the problem is a geographical one, Jeff.
Okay.
When you're on Maui, it's just, I mean, it isn't exactly, you're not inundated with options in remote Maine, in rural Maine. But when you're on Maui, it's just not that easy to bring these other players in, and especially when you've got a doctor who doesn't want to talk to anybody else and thinks he knows everything. And, you know, I can accept that an adversarial approach may not be the best, and you know, I hear the doctors saying it. The doctors being Jay Burton and Steve Bornstein, because they don't like it. But the fact is that when you've tried everything else and you've tried to be collaborative and you've suggested to the doctor that he be collaborative, I don't know what else is left. And you know, I think it's probably more adversarial to go to the state board than it is to put in writing the treatments that you'd like to have. You're not telling him, give me these treatments. You're asking him for these treatments. There's a difference between asking him for a treatment and telling him that you must have this treatment. And I'm suggesting you put it in writing that these are the treatments that you want. If, you know, and then we've also got a man in Mike Tamales who, you know, sometimes I think he's probably ready to crawl up in a corner and just pass away, which is also very sad. And we want to try and do the most we can for him, but as I've said to Peter, if he's not willing to go to bat for himself, then we can't knock ourselves out for him. So it's a little more complicated. I mean, hopefully we'll get to speak to Peter later tonight. I don't know. It's easy. It's an easy situation to say what not to do. It's not an easy situation to know what to do. All right, Jen.
Yeah,
Go ahead.
I'm in a conundrum, really. I'm not sure what to do. I really don't want to go in there adversarial. I'd rather talk about it than have it in writing. It seems like confrontational, but it's kind of one of the choice do I have.
Well, you know, the choice you have is to stick up for yourself, Mike, as we've said to you. I'm sorry. I'm sorry if I said anything that offended you. I truly apologize. I didn't realize you were still on the call. I thought Mike said both of you were going to hang up when he left, and I do apologize to you.
No. Say what's on your mind.
You know, you are your best advocate. And I'm not saying go in and tell the doctor what to do. I'm saying go in and tell the doctor what you want. There's a big difference. And you have to be assertive in what you want, the treatment that you want.
It's kind of hard for me to know the treatment that I want when I really don't know much about the subject.
But that's why you're on these calls, and that's why we're informing you.
Yes.
You know, when you have a doctor that recommends a treatment for you that clearly should never have been recommended because you weren't fit enough to have that treatment, I think that you know, it's all well and good saying, well, you know, just don't be confrontational with the doctor. Don't tell the doctor. Just go along with him. But no. I mean, those are doctors saying don't confront. Because the doctors don't want to, I mean, however good the doctors are, and, you know, and I have a lot of respect for both those doctors, and I love Steve. Steve is great. But he's still a doctor, and he doesn't want a patient coming in and saying to him and putting him in a difficult spot. But, you know, I don't know what to say here. This isn't medical advice. This is navigation. This is how to handle a doctor that is giving you bad advice and recommending treatments that he shouldn't be recommending. There's no question. He should never have told you to go off the Provenge when you already were sick and you had the flu or whatever you had, and when you were on those drugs. And you were about to, and he was going to have you do Provenge at the same time as Zofigo.
Yeah, on top of taking my Zytiga shot, and I just had my my 3-month Lupron shot too.
So some things are fine. I'm sure the Lupron is fine, but the people at Provenge say, as you heard, don't do Zofigo and Provenge at the same time. So, on the one hand, yes, we don't want to be confrontational. On the other hand, we don't want to have him send you for a treatment that kills you. And then what's he going to say? Oh, well, I didn't understand. I didn't know. Well, he should have known.
Yeah.
That's his job. That's what you pay him for. You're not paying us.
Yeah, I got you.
And then if it wasn't for Peter, we wouldn't. Peter was the one that went in and checked out on the opioids. You're doing opioids, you should not be doing Provenge. It's right there. So, I stand corrected by the doctors on the call, but I still think that it is not a bad idea to put in writing what it is that you want.
Oh, okay.
And, and that's what I would suggest you do. You put in writing what it is that you want, but at the same time, Mike, you must help us by asserting yourself and saying, yeah, this is what I want, and telling him that. And also, we need to find, as Jeff Ledoux has pointed out and others have pointed out, we've got to put a new medical team together for you.
Yeah.
Richard.
Yes.
One last point that I do, and I've got 2 books now that are 4 inches thick with all my records, all my medical records, and a journal. The journal, at the end of it, before I go into my next appointment with my oncologist, I have at least 3 questions that I want to ask him about. Are we going to do this for a treatment? Are we going to do that for a treatment? Where are we going to go from here? And he'll sit there and he'll talk to me for a half an hour, 45 minutes, and we will either decide to do it or we'll hold off on it. And that's where we are. But that's what I do. And that's not medical advice. That's just my own obsessive compulsive disease.
Right. I mean, Mike, we know you're not an expert, but we try to provide you with the information so that you can advocate for yourself. If you don't want to advocate for yourself, there's only so much I can do, Peter can do, and all the other guys on this call who want to see you get the best treatment can do for you.
Yeah.
Okay. All right. Again, I'm sorry. I'm sorry if I offended you or I said anything.
No, not in the least. Just trying to line up my ducks.
All we want is for you to get the right and the best treatment as soon as you can. And I really want to see you get sequenced with a recent sample, whatever it takes to do that. That is just a no-brainer. You might be like Frank and it won't show anything, but you may be one of the lucky ones where it does show something, and a year from now you're going to be in a much better situation. I've said it before. I promised myself I wasn't going to let this happen after I saw what happened with Trevor. I wasn't going to let it happen again, and so I have nothing to do with it. All right, guys. We filled up the 2 hours again, and we're going to have to wait with bated breath to hear Len's report on Mike Morris. But I think you guys can wait. Okay. Go sign up on Amazon Smile. Okay.
All right. Good night, Rick.
Good night, everyone.
Thank you, Rick.
Good night, Rick. Thanks again.
Thank you.